All right, so today we are going to get started on chapter 15. So for chapter 15, what we're going to be learning about are the actual pathways that are going to help us with picking up our sensory information. Later on, we will go into the motor pathways. So we're going to divide it up into sensory and motor. And whenever we say sensory, we're going to be focusing on the general senses instead of the special senses. So general senses like touch and pain instead of special senses like vision and taste, okay? And then whenever we're looking at this, the motor pathways that will come later on are going to be involved with the somatic nervous system that is going to control our skeletal muscles. So if you remember, as we went through our spinal cord, there was a part of the spinal cord where we talked about somatic sensory, visceral sensory, somatic motor, visceral motor. So this is just kind of a recap of some things that you guys kind of already know. So now if you start seeing something that says GSA, that is basically what we referred to previously as somatic sensory. It's general somatic afferent. It's the same thing, okay? Since we're focusing on general senses, that's where that G comes from. And then for our general visceral afferent, GVA, what we originally labeled on our spinal cord as the VS. And then same thing here, somatic motor, visceral motor, you may see these GSE and GVE. Now, for the general visceral efferent, this is going to be involved with the autonomic nervous system. So this actually comes in chapter 16. So this won't be in this chapter at all, okay? This chapter is all about our sensory and then motor for the somatic being the primary and the predominant thing that we're going to be talking about, okay? So just to remind you, you have your spinal cord drawing that looks something like this. Just recap, make sure you remember our afferent, our sensory information is always going to come in through the dorsal root. You guys remember what this is called, right? Dorsal root ganglion, very good. So we've got cell bodies that live in the dorsal root ganglion. So this information is going to come either into the somatic sensory nuclei area of the posterior horn, or we've got visceral sensory nuclei, so that's our SS and our VS, as I was just talking about. And then of course in the lateral horn, we're going to have our VM, that's our visceral motor, and the anterior gray horn, we have our SM, our somatic motor. So this is all just a recap. You just want to make sure that you remember whenever it comes to the somatic sensory and the visceral sensory, because we're going to be talking about so much sensory today. Remember, somatic being associated with skeletal muscles, and of course visceral is associated with anything that has to do with the organs. So we're going to kind of talk through in more detail than we went into with the spinal cord chapter of what exactly are we talking about when we look at these pathways and how information actually gets from the periphery and then is into the spinal cord and or into the brain. So our somatic sensory information is going to be distributed to the sensory processing centers in the brain, either the primary somatosensory cortex. So just remember, this was the post-central gyrus. The post-central gyrus is in which lobe? Parietal, very good. Or it will be going to appropriate areas of the cerebellar hemispheres. Next time is whenever we will walk through the paths. So you will see that there are some things that are going to go to the primary somatosensory cortex, and then some things that are actually only going to go to the cerebellum. So you'll be able to see the difference in those pathways. And then visceral sensory information is distributed to the reflex centers in the brainstem. Remember, brainstem meaning breathing and being alive. That's what we want to think about with the brainstem. So visceral sensory having to do with digestive, cardiovascular, all of those things, respiratory. That's visceral information, very important for it to go to the reflex centers in the brainstem and or the diencephalon. Okay, so for our efferent, remember efferent, again, recap. This is motor, so this is going to be coming out of the anterior root of the spinal cord. So we're leaving the anterior root in order for motor information to travel from the CNS towards the PNS. So the CNS will carry from the CNS, that information will be carried out to the periphery towards the PNS so that we can make a change in some particular area where there needs to be a change in order to maintain homeostasis. You can see here that the somatic efferent looks quite different than the visceral efferent. So what you want to make a note of right here is on your somatic efferent, you can see we have this neuron that looks very similar to the one that we drew. And we have our myelin sheaths surrounding this axon, and we get all the way down here to the synaptic terminals, and we can see actually the release of the acetylcholine. So we're familiar with this already because of the things that we have drawn in class. Now, this is the visceral efferent. You can see here that that does not take the same pattern as the somatic efferent. We do have what we kind of drew in class, and then we have the acetylcholine being released. However, what we now have here is this addition of this autonomic ganglion. A ganglion is just a cluster of cell bodies, okay? So the autonomic ganglion is new, and now we have two different structures that are going to be carrying the information to the final destination. This is where we will get into talking about the autonomic nervous system in chapter 16. Okay, so this isn't coming right now for chapter 15. This is just to show you the difference between what would happen with the somatic efferent, which you've already learned, versus the visceral efferent, which you will see there is going to be some differences as we walk through chapter 16. Okay, now again, same thing, just a recap. We know that in order for us to have some awareness of the fact that there is a sensory stimulation, we need enough stimulation for there to actually be a threshold that is reached to generate some action potentials. So everything always starts with a stimulus at the receptor, okay? There's stimulus at the receptor. If it produces a strong enough change in that membrane potential, then we will get to threshold. And you guys remember what that number is, right? Threshold? Negative 55, perfect. If we get to the negative 55, we can get our action potential generated, and that action potential can then carry the signal or the information along the entire neuron in order for it to get into the central nervous system for processing. And of course, we already know based upon our reflex arc that we kind of went through from the CNS processing, we're then going to get the motor information coming out. Okay, so motor path involuntarily, this is going to be which part of the nervous system? Because it's involuntary. This would be what? Sounds like automatic.
Autonomic.
Autonomic, perfect. Okay, so that's your answer right here. All of this motor pathway, this involuntary, this is all chapter 16 for our autonomic nervous system. This pathway of the voluntary, this is what we will walk through with chapter 15 for our somatic response, okay? As you can see here, about 1%, circle that, 1% of arriving sensations are going to be relayed to the primary somatosensory cortex, which means only 1% of that sensory information actually reaches your conscious awareness. 99% of things are not going to actually reach your conscious awareness. So it's quite a bit of sensory stimulation that your nervous system will help to kind of keep quiet to not overwhelm you. So this is what we'll be walking through and we'll be talking about in greater details. Sensory pathways are a series of neurons that, again, relay sensory information from the receptors. Remember, we always have to start at receptors into the central nervous system, either the brain or the spinal cord. The receptors are going to be the specialized cells or the cell processes that will monitor specific conditions, and then when they are stimulated, they can generate those action potentials to talk to each other. Because remember, action potential is all about how does the neuron communicate and tell the other parts of the body what's going on. It all happens through the action potential. So here's a new word. Highlight this word or circle it, transduction. This is the conversion of that arriving stimulus into the action potential by the sensory receptor. Okay, transduction begins when a stimulus, we always start with the stimulus, changes the membrane potential of the receptor cell. So we've got to change it, of course, in order for us to be able to reach threshold, in order for us to have an action potential. So transduction, when we're talking about this, for transduction, basically what this means is by converting that stimulus into an action potential, then your body can become aware of that sensory information. So if you think about it, there are things that surround us that you maybe are not aware of completely. Like if you go to the dog park and somebody uses a dog whistle, it does not sound like the whistle at a referee, from a referee at a basketball game, right? So we don't have the same receptor in the dog's ear in our ear. So we're not picking up that, so therefore we cannot transduce that. And therefore we are not going to be aware of that sensory information. So the transduction is all about that stimulus turning into an action potential because of the changes in our receptors, changing those membrane potentials and sending that signal along the pathway. You can see some of those receptors here. Taste, hearing, equilibrium, and vision have their specialized receptor cells. They all look different from one another. So when we're talking about the eye, the photoreceptors are called the rods and the cones. So the rods will pick up in dim light, and the cones will pick up very good in color. So dim light for rods means that you're not really going to be able to see color differentiation. Black and blue look the same whenever you are in the dark or whenever you're not in a well-lit area. Whereas the cones are going to be for color differentiation in a bright light. So those photoreceptors both work with different levels of stimulation depending upon how many photons are obviously in that light spectrum. Hearing, you can see here we have multiple different types of receptors in our ears for hearing as well as for balance and equilibrium. Olfactory, cranial nerve number 1 helps us pick up the sensation of smell. And then in our taste buds, in our tongue, different receptors here with, you can see these little microvilli that will reach out and catch those chemoreceptors in order for that transduction to take place so that you can taste different things like bitter, sour, sweet, etc. So these are going to be using chemical synapses, and that's what we're familiar with because that's what we drew, right? Using like the acetylcholine or some other type of neurotransmitter across the synaptic gap. That is a chemical synapse. So for sensation, if we're talking about something and we say bottom up, that means the information is arriving into the central nervous system from the periphery. Okay, so bottom up is arriving information. Now, perception is not the same as sensation, so you don't want to get those two confused. Perception is your awareness of something. So you can have lots of different sensations and not actually be aware of them, because remember, only 1% is going to come to our conscious awareness. So the perception, therefore, is the top down. Instead of bottom up, it's now top down. Perception means that it has reached your brain and now you are aware, so now there can be some sort of action that is taken top down, from the brain going down in order to maintain homeostasis, depending upon what that sensation was. So if you walk outside and like today it's like super cold, your perception of the temperature is it's freezing out here. Okay, well, at least for us Texans, it's freezing out here. Anybody who's from up north, they're like, oh, this is great. Okay, but for us, we're like, put on a sweater, put on a jacket, because our perception is it's too cold for me to walk outside in a t-shirt. All right, so that's how we're looking at the difference between the two. Now, When we're talking about our receptors, we have two different things that we want to make sure that you can identify and point out. Tonic receptors are those that are always active. So I think about these like the green light go. It's like the light is always green and these things are always ready. So they are always active, always working in the background, even if they're not stimulated, they're always on. They are slow adapting, which means that they show very little ability to adapt regardless of the stimulus. And when we look at this, it makes more sense if you talk about pain receptors. Pain receptors are called nociceptors, and nociceptors are those things that are tonic receptors. They are always on, and they will always let you know if you're doing something that's going to cause your body pain, okay? One day I was actually in lab at a different college, and with the way that we have the stools set up in the little lab tables, I accidentally pulled the stool up and I didn't realize that my finger was going to be caught underneath the table. And so as I pulled the stool up, it popped up so fast, it smashed my thumb in between the table. Now, my thumb sat there for a good 30 seconds before I could figure out how to get the thing back down, but the pain never stopped. I never was able to adapt to the pain. It never went away because these tonic receptors are always on. So whenever we're talking about slow adapting, that means that nociceptors especially are going to let you know that there is an issue. They're not going to turn off, okay? So they will continue to respond as long as the painful stimulus continues. Central adaptation may reduce the perception of the pain, however, even if the nociceptors remain stimulated. Because I always get the question right here in this particular area, well, if pain receptors are always on and they always stay activated, how can people stand to get tattoos? Because that's a lot of pain for a really long time. And so what it is there is a central adaptation, not a peripheral adaptation. The central adaptation is more so related to the brain, not necessarily to the nociceptor itself. So if you've ever heard someone say, you know, the battlefield of the mind, or take your mind off of it, try to think about something else, that's what they're referencing. The central adaptation means that you can, with your own brain, start to inhibit some of these centers so that you perceive the pain to be less than it actually is, okay? All right, so this is a little graph that shows our tonic receptors always being active. So you can see even just with a normal stimulus, they're on. But with an increased stimulus, the frequency of the action potentials is going to increase. Okay, but they always remain on. Whereas a phasic receptor is normally inactive. So the inactive receptors will provide information about intensity and then the rate of change of a stimulus, and they are fast adapting. So they usually will respond very strongly, but then their activity will decrease because eventually your phasic receptors are going to adapt to whatever that particular stimulation is. So if you've ever changed a baby's dirty diaper, then you know they can smell horrible. And like at first, you know, you're like, oh my gosh, I don't know if I'm going to make it through this. But then eventually, as you're changing the baby's diaper, you're like, okay, I can do this. That's because odor is going to be something that is fast adapting because it's a phasic receptor. We probably wouldn't be able to have people who worked as trash men and women if this wasn't a fast adapting receptor, because that would just be horrible smell all day long. Like if you were never able to get past it, that would be a very rough job. So fortunately, odor is a fast adapting phasic receptor. And so here you can see the graph on this one. Now what you see the difference is on this line, there are no marks for the action potentials in normal. There's only going to be the frequency of action potentials in an increased stimulation. And that's because they normally remain inactive. So this is like the red light, okay? Not green light go, but red light. And then if something stimulates it, then it'll go. Okay, and then here's the information about adaptation. So for adaptation, we're either going to have a reduction of the receptor sensitivity, kind of like what we just talked about with the odor. So that's a reduction of receptor sensitivity, or that decrease in perception that I was talking about with pain whenever you're in the presence of a constant stimulus. If we say peripheral adaptation, then of course this means it's in the peripheral nervous system when the level of the receptor activity actually changes. And this will reduce how much information actually goes into the central nervous system. Versus central adaptation, it will involve inhibition of the nuclei along that sensory pathway. Now, the nervous system, fortunately, will quickly adapt to painless, constant stimuli. So if you think about putting on your clothes each day, generally you're going to wear comfy clothes and your body is not going to think about those all day long. You're not going to have an awareness of, you have clothes on, you have clothes on, you have clothes on, you have clothes on, that's not going to constantly be going to your brain, because that is then going to overwhelm you, of course. So a painless, constant stimuli, the nervous system will quickly adapt to that. All right, here's our list of our general senses. So whenever we walk through our pathways next time, we'll be talking about specifically what are the pathways that are going to carry all of these senses. And then, of course, our special senses are those things that are going to be the things that we learned in kindergarten, like you smell with your nose and you hear with your ear, right? So we're not going to be walking through all of those individually. Now, although these individual receptors respond to only one type of stimulus, like it might be temperature or it might be touch, a stimulus in the real world almost always activates several kinds of receptors simultaneously, okay? So just keep that in mind. We'll go through them one by one, but usually it's going to be multiple and not just one particular one. So for our sensory receptors, we have actually learned this before. This is just a recap, but I wanted to remind you, extero meaning the external environment. Proprio is position. So if you have your right arm up and your hand is raised, then your body is, or even if your eyes are closed, your body is aware that your right arm is up and your hand is raised. It's not your right knee. Okay, so proprioception will tell you where are different parts of your body at in space, even if you can't see them. You're aware of what's happening with them. The entero, again, internally. So for our visceral organs, they will have fewer pain, temperature, and touch receptors than other body areas, and the information from these receptors is poorly localized due to very large receptive fields. So I'm going to talk about receptive fields in just a minute. So just underline this, that your visceral organs, poorly localized, large receptive fields. Okay, so even though they have them, I'll show you how, not today, but another day, how if there is a problem with those organs, then those receptors are actually going to communicate sometimes in really funky ways. So we'll walk through that a little bit later on. So I put this picture in here so that you could see proprioceptive endings. Okay, proprioceptive endings, we have this black line right here. If you trace the black line all the way up, then what you get is general, somatic, afferent, proprioceptive fiber. We have nociceptive and thermal endings on the red line. Trace it all the way up. We've got the general, somatic, afferent, extero. Okay, pain, temperature. That is external environment. Viscero, we trace the green. Keep going. General, visceral, afferent, entero fiber. So you'll have to know that through this, even though we drew our spinal cord, when we drew our dorsal root, there wasn't this much information in here. All we said is that this is all going to be afferent. Now you can see that it's split. All this sensory information will take the same route, but they each are going to stay in their own individual space. So you guys can see that there's a lot of information that's going to be traveling through this sensory route right here. Make sure that you understand the difference in what sensory receptors are going to be carrying the information. Where would that information ultimately be coming from? So if we're talking about a knee that is twisted during a basketball game, that's going to be a proprioceptive receptor, okay? Because the position of the joint has changed. So if we're talking about, let's say, a stomach that is completely empty because somebody hasn't eaten in 14 hours, that's a viscero. So that's going to be interoceptor. That's going to be picking up on the fact that that stomach is empty because somebody hasn't eaten in hours, okay? So you just kind of have to separate those things out as to where is that information actually coming from. This is the what, okay? Let's go back. Where, what, where in the body or where in the environment, okay, because we can have it external, and then what. So what are we trying to pick up? What do we need to know? So is it pain? Is it that the temperature has increased or decreased? For chemoreceptors, these are going to be things that are going to be like carbon dioxide and oxygen. You'll be able to pick up chemoreceptors in the air as well. Whenever somebody sprays some perfume, you'll be able to smell the difference in their perfume. That is all going to go into cranial nerve number 1. Okay, mechanoreceptors. So this is like the things like touch. So we're going to walk through each of these, and what I have done is I have color coded them for you. So that way, as we're walking through the PowerPoint, you'll be able to refer back to this particular slide right here and say, okay, what are we talking about again? So green, yellow, red, and blue. Okay, the majority of information is going to fall under the blue category. So you're going to see there's going to be a lot of blue. Okay, so nociceptors. These are free nerve endings. So highlight that, free nerve endings with very large receptive fields. And like I said, I'll talk about receptive fields in just a minute. They're more common in areas of your skin, joint capsules, around blood vessels. And these are the things that free nerve endings can be sensitive to. So this is the information, the what, that can be picked up from free nerve endings. So you can even see here, it can get a little confusing because you see this temperature extremes. Thermoreceptors pick up our temperature, but now we're talking about nociceptors. Obviously, if you're out in the cold for a very long time, you have on no gloves, your fingers start to turn blue, they start to hurt, right? So we're going to have those nociceptors in the skin that can pick up the changes from those temperature extremes as well, because that's a sign that you have got to do something different before you lose your fingers to frostbite. Pain receptors will always be your signal that you've got to do something different. Okay, nociceptors you will see associated with myelinated type A fibers because they carry the sensations of fast pain. Fast pain is that whenever you get an injection or whenever you are in the kitchen and you cut yourself really deeply with a very sharp knife. That is fast pain. So the sensations will reach the brain and the spinal cord very quickly and often will trigger those somatic reflexes relayed to the primary somatosensory cortex, and they will receive our conscious attention. Okay, again, remember this is the postcentral gyrus. So if we get here, anytime we get here, we will know what is happening. We will be aware. That will be part of our 1% that we are familiar with. So here's an example for you, just showing you on the picture, the pain pathway. So it looks like this man stubbed his toe right here. And so what you can see from the toe all the way through the afferent nerve fiber up into the spinal cord, all the way up to the brain, ultimately coming to the somatosensory cortex for our conscious awareness of that particular pain. And this is going to run through the very fast fibers. Now, I circled this over here for you, the spinothalamic pathway, because this is one of the things that I'm going to talk about next time. Spinothalamic, when you hear that word, you should think pain. Okay, because we'll talk about a lot about how pain is going to be carried through that particular pathway. So that is spinothalamic with the pain pathway. Can you change your mind about pain? Yes, yes, you actually can. So our sensory neurons that bring these pain sensations into the central nervous system will release glutamate and or substance P as our neurotransmitters. These can affect the level of pain experienced and can be out of proportion to the amount of painful stimuli or the apparent tissue damage. What this means is there are people out there who say that they are in pain all the time, when in reality, the amount of stimuli that should be causing the pain and or the amount of damage to the tissue that we expect to see with somebody who says, I have a 10 out of 10, is absent. Okay, so there is ways for you to alter what's going on in your brain about perception of pain, both increase and decrease, which is very interesting. So we can say that there's actually more pain than the body actually shows. And sometimes it could be because these neurotransmitters are in high levels. Sometimes it's other issues. Sometimes it's some psychological things.
So when people have like fibromyalgia, is that how?
That's part of it, okay. Yes. So, and then fibromyalgia, unfortunately, is also a what we call trash can diagnosis. So that just basically means when nobody can really figure out what it is or explain the pathways as to why this person is feeling this way, then we're just going to put them in this category because we don't really know. So that's the unfortunate part about that diagnosis. That is a part of it with fibromyalgia. There's a whole lot of other components that go into that as well. Neuromodulators are important because we have these neuromodulators, endorphins and enkephalins, that can reduce the level of pain that a person feels. So they're structurally similar to morphine. They're found in the limbic system. What do we know our limbic system is associated with? Emotions, right? So our emotions can affect the levels of pain. The hypothalamus, the reticular formation, and can inhibit activity along pain pathways in the brain. The interesting thing about this is when you're looking at these neuromodulators, the endorphins and the enkephalins that will help bring pain down, you guys remember the assignment that I gave you for the endocannabinoid system? And so one of the things that they said were those are supposed to be in our body and they attach to our receptors and they help with modulating different levels of pain. But it's very important to have the omega-3s that your body needs as well in order to help maintain homeostasis in that system. So that fibromyalgia patient as well, one of the first questions that I always have to ask too is, what are you taking? What is coming into your body every single day? Because if they're missing something or they're taking something that's causing them an imbalance, then that's something that we need to address right then and there. So we could say, all right, well, let's just make sure everybody has more endorphins and enkephalins, but the problem is it's not very straightforward. That's why I put this down here. Sometimes you can't always separately identify the effects of these two systems, and they do very much intermingle with one another. So why some people are not able to release that pain level to what we would consider appropriate level is still unknown. So there are many people who walk around in pain every single day, although there is no reason, according to MRIs, labs, et cetera, for them to be in that level of pain. Very interesting. Okay, unmyelinated type C, these are slow pain fibers. So the burning and the aching pain is going to go through C. Whenever you have this type of pain, basically this is an awareness, but you just have a general idea of the area affected. So whenever you say, I mean, I just kind of ache, like it's just all kind of like right here, you can't necessarily pinpoint it because it's very diffuse. So that's going to be your type C fibers. Now, just to take note, tickle and itch sensations are not fully understood, but they are closely related to sensations of touch and pain. So free nerve endings will carry this information, the tickle and the itch, through the type C fibers, which is why some people really hate to be tickled because it's not a pleasurable experience. For some people, it is actually painful. So again, everybody is different. All right, so here again, looking at your type C fibers in this particular example and your spinothalamic tract. Obviously, spinothalamic means from the spine up towards the thalamus, and then the thalamus will send the information up to that somatosensory cortex. All right, thermoreceptors. Phasic receptors, so they will adapt. That's why whenever you go outside and you are in the cold, you walked in here in the building and you may have been like, oh my gosh, it's so hot in here, but eventually your body kind of got used to it. Okay, so they are quickly adapting. Free nerve endings as well for the thermoreceptors. We've got these in multiple different places in the body, and these sensations are conducted along the same paths that carry pain. So temperature and pain are going to go in the same pathway. Cold receptors, highlight 3.5 times more common than heat. 3.5 times more common than heat for our cold receptors. So here is just an example for you, different types of thermoreceptors that you would have, whether in your skin or in your viscera, like in your liver, in order to help with regulating your core body temperature. So whether you need to constrict and make sure you do not lose heat, or whether you need to dilate and release water through your sweat glands in order to give off heat, all for the purpose of maintaining that 98.6 degrees of your body temperature. Chemoreceptors, I'm only going to go over this briefly because we do talk about this more in 2402 when we go through cardiovascular and respiratory. So chemoreceptors, just know that these will respond to our water and lipid soluble substances that are dissolved in body fluids. So this information will not go to the somatosensory cortex. That is why you are not aware of this information. This information only goes to the brainstem. Okay, so you can see that they will be monitoring various chemical concentrations of the blood, because it's very important for the blood to stay tightly regulated. We have carotid bodies and aortic bodies that are going to help give us our chemoreceptor information, and they are linked to different parts of the medulla oblongata. So you can see chemoreceptors here in the neck, chemoreceptors in the heart. They talk to the chemoreceptors in the medulla oblongata in order to make sure that your lungs and your heart are working appropriately to maintain all of these very important chemical levels that your blood requires. Mechanoreceptors. So when we're looking at mechanoreceptors, this is the ones that are associated with touch. So they're sensitive to physical stimuli. Physical stimuli, not temperature, not chemicals, but physical stimuli, anything that's going to distort their plasma membranes. And when those plasma membranes get distorted, those ion channels are either going to open or close, which is then going to change the cell's measurement on the inside, which means we may start getting some action potentials, okay, just depending upon the stimulus. So we've got 3 classes of mechanoreceptors. You can just label these number 1, number 2, number 3. 3 classes of mechanoreceptors include the baroreceptors, and again, this is another one that we talk about more in 2402, so only going to slightly mention it here today. Baroreceptors, what you want to know about those is they detect pressure changes. Your pressure changes are very important, especially whenever it comes to cardiovascular, right? We all know how important blood pressure is. So baroreceptors help us detect our pressure changes in various parts of the body, not just cardiovascular. Proprioceptors, as I said earlier, these are going to monitor the positions of joints and skeletal muscles. And then tactile receptors. These are the ones that you became familiar with from the integumentary system. So we're going to walk through those again today, just to give you a refresher and a recap on those different tactile receptors so that you can see what each one is going to be picking up in regards to sensation. Now, sensitivity to tactile sensations can be altered by infection, disease, or damage to sensory neurons or pathways. So if somebody does not have the sensation of touch anymore because of something that has happened, an injury or something of the sort, then yes, this is going to be altered for that particular individual. So we're just going to walk through physiology, not necessarily the pathology. All right, so there's your information about baroreceptors, kind of what I already said, monitoring pressure in an organ. Here's some places where you can find baroreceptors. And again, we'll go through this in 2402. Proprioceptors, these are the three places where you want to make sure you know proprioceptors are found. As we go through the skeletal system or the muscular system, we'll be talking more about proprioceptors as well, because we'll be talking about all of these things once we get closer to test 4. Now, there's no proprioceptors in the organs. That's why you don't know where your spleen is or where your pancreas is. I think it would be kind of cool to be able to know where all of those things are and to actually feel them move. That would be awesome to me, but I'm just a weird person like that. So there are no proprioceptors there. All right, here's our 3 major groups of proprioceptors: the spindles, the GTOs, and then the receptors in the joint capsules. They each have different jobs that they need to do. So our spindles will trigger those stretch reflexes because they're monitoring the skeletal muscle length. We don't want to stretch our skeletal muscles too far because stretching them too far could lead to injury. So the stretch reflexes means we quickly learn how to put our muscles back where they need to go in order to avoid tearing them. Golgi tendon organs, these are going to monitor tension during muscle contraction. So this is why whenever you try to lift weights, you cannot lift an unlimited capacity because the tension is too strong and the Golgi tendon organ is saying, nope, that is too much for you, put that down, quit trying to act like that in the gym, don't be a show off, okay? Receptors in the joint capsules will be the free nerve endings that detect pressure, tension, and movement. All right, so here's pictures of our muscle spindles and our GTOs, and you'll get more information on these as we walk through the muscular system. So let's go through our integumentary system receptors. The 6 types, obviously free nerve endings, I've said that like 1,000 times already, so you should be able to easily identify what a free nerve ending is going to look like, and make sure that you know that they are sensitive to that touch, pain, temperature, and pressure. So they are tonic as well. Remember that, tonic. And these are the only receptors on the corneal surface of the eye, which is really cool. But that's one of the reasons why you cannot touch somebody's cornea without them blinking, right? Because they have these free nerve endings right there, and that touch sensation is going to automatically cause them to blink their eye. So that way you don't hurt their eyeball. Root hair plexus, obviously this is going to be that free nerve ending that is attached to the root of a hair. So they adapt rapidly. This is why they can pick up sensations of somebody brushing through the hair, somebody pulling the hair. They do adapt pretty quickly. So any distortion and any movement of hairs for that free nerve ending wrapped around that root plexus. Tactile disc, you can see here, Merkel cell is another AKA. So Merkel is fine touch and pressure. sensitive to shape and texture, extremely sensitive tonic receptors. So extremely sensitive means that it does not take much for these to be activated. That's why they are associated with fine touch. You barely need to even touch anyone for you to stimulate their Merkel's disc or Merkel's cell. All right, and they have very small receptive fields, which means it's going to be very easy, even if you lightly touch someone, it's going to be very easy for them to identify where you are touching them. They will know, are you on my shoulder? Are you on my knee? Okay, are you in my ear? Wherever. So very easy for them to localize because that receptive field is small. Rufinis, I like to call these Rufinis instead of bulbous corpuscles because I just like the name a whole lot better. Rufinis are going to be sensitive to the pressure and distortion of the skin. So like if somebody were to walk up to you and like twist or try to stretch your skin, that would be Rufinis. Tonic receptors, little adaptation. Okay, it doesn't feel very good to have your skin just twisted, so that stimulus is going to kind of stay there as long as someone is twisting your skin. So little adaptation. And instead of calling these lamellar, I like to call these Pacinian because Pacinian starts with the P, and these are responsible for deep pressure. So I like to put the P's together, Pacinian for pressure. Fast adapting. These are sensitive to either that pulsing or the high frequency vibrating stimuli. So if you've ever used one of those massagers that like pulse and vibrate whenever you hold it up to your back or to your skin, this is what's going to pick up that particular sensation of that vibration is going to be that Pacinian. And then we also have Meissner's. So just another type of tactile corpuscle that you can find within the skin area. Again, sensitive to fine touch, just like Merkel's. So Merkel's and Meissner's both do that fine touch. But this one also does pressure, low frequency vibration. Most abundant in eyelids, lips, fingertips, nipples, and external genitalia. These things all have in common the fact that they are highly sensitive areas. You do not need to do much in order for an eyelid to feel like it is being messed with, okay? All of these areas doesn't take a whole lot in order for these things to be stimulated. So highly, highly fine touch. Now, receptor specificity. Whenever we're talking about specificity, each receptor will have that characteristic sensitivity. As we walk through and I talked about this is for touch and this is for pain, this is for deep pressure, this is for vibration. That's what specificity means, as well as is it going to be a chemical or is it going to be a touch? So specificity for each of those receptors. Free nerve endings will extend, like you can see in the picture here, just kind of like grass roots extend in the soil. Therefore, they have many different stimuli that can stimulate them. You kind of saw this as we walked through all of those different things because you saw, okay, it'll pick up pain and it'll pick up temperature and it'll pick up touch. It does all of these things. So whenever we're talking about free nerve endings, we'll say it has low specificity, okay? Low specificity because it will do so much. All right. Now for our fields, this is the area monitored by a single receptor cell. Just one receptor cell will be monitoring a field. But the larger the field, the more difficult it is to figure out where is that stimulus coming from. So the example that I put up here is in the eye. Whenever we're looking at the eye, this particular area here called the fovea centralis, this is where you want the light to ultimately refract and hit on this particular portion of the eye in order for you to have that good 20/20 vision. If the light comes in and it bends and it refracts and it doesn't hit the fovea, then your vision is not that great. That's why you get glasses or contacts to help the light bend in the correct way so that it hits the fovea. Why is the fovea important? Because this is where you have all cones. And all cones means this is the area where you will have the highest visual acuity because you have so many photoreceptors sitting right here in this very small receptive field. Okay, so anything that's small is very easy to localize that particular information. Anything that's large, it's kind of hard to figure it out. So let me show you another example. When we're looking at the skin, so this is obviously a picture of the skin, right? There's two different receptive fields on this skin. If we're talking about the arm, each sensory receptor will gather information from a large skin area, whereas if we're talking about the fingertip, it's very small. So we have receptor fields that can be large and it's hard to localize, or they can be very small and it's easier to localize. The other important component is receptor density. So highlight that word right there, density. The more receptors you have in a particular area, the easier it is for you to figure out where that sensation is coming from. So this little picture that I have over here, these are things that I actually have in my doctor bag. So whenever I go travel, these always come with me. What you can't see on this picture is that these little things, these spikes here, are labeled with numbers. And so what they are is they've actually identified, like if we say this one right here is probably a 2 millimeter, 3 millimeter, 4 millimeter, 5, 6, 7, 8 millimeters, and these get larger and larger. Whenever we're trying to figure out if someone has any sensory deficits, if we take this little tool and we poke it on their fingers, I have that person tell me, do you feel 1 prick or do you feel 2? And if they only feel 1, then I'll go up higher. So I usually start about the 4. If they only feel 1, then I'll go up to 5. And if they still say 1, then I'll go up. I'll keep going up until they tell me that, oh, I feel 2. And basically the higher the number, the poorer the sensory innervation. So the higher the number, the more messed up their sensory nerves are. I need somewhere between a 2 to 3 millimeter for a quote unquote normal. Okay, that is normal, somewhere between 2 to 3, because your fingertips have such small receptive fields and such high receptor density that you should be able to feel the difference between 2 points anywhere from 2 to 3 millimeters. I had a guy who actually had, he was working for the prison system and he punched an inmate in the head because the inmate came after him. And whenever he punched the inmate in the head, he actually broke one of his metacarpal bones. And whenever he broke his metacarpal bone, he already had osteoarthritis. And so it triggered some inflammation in other joints in the skin. And then he also got trigger finger on one of his, which just means that basically the joints didn't work like they're supposed to anymore. So whenever I tried to poke this guy's hand with my little device, he could identify nothing. And so we just kept going up and up and up and up, and he couldn't feel anything because of all of the damage that had occurred, even after surgery being done in order to try to help repair all of that. His sensory nerve still had problems. So this is a good way to kind of identify if there is something that maybe people can't necessarily tell you about. So again, 2 to 3 millimeters apart on the finger because of the small fields and the density versus 35 to 40 for the arm. That's a major difference. Okay, so the arm fields are much larger and the receptor density is not as high. Okay. Each sensory, let me move this out of the way. Each sensory receptor connects through a series of relay neurons with the central neuron. So that given central neuron responds to all information from its input area as if it were coming from one point. This is the receptive field. Okay. So basically it's there to monitor. The receptive field is the monitor area for these neurons to tell you what is going on where. If we're talking about interpretation of sensory information, then we're going to be talking about labeled lines. So this is something that's new. The stimulus will reach the cortical neurons via what we call a labeled line. And each labeled line will carry information about one modality or a type of stimulus. The frequency and the pattern of the action potentials will contain the information about the strength, the duration, and then the variation of the stimulus. And your perception depends on the path it takes inside of the central nervous system, especially where in the brain the information ends up. The somatosensory cortex is very specific, and I'm going to show you guys that next time. If something is coming from the toe, it will go to a specific area of the somatosensory cortex versus if something is coming from the shoulder. So where in the brain the information ends up is incredibly important for how you're actually going to perceive that particular information. So this is just a very, very basic labeled line graph that will show you for our nose, we've got smell, it's going to be going into the limbic cortex. The eye will carry vision, the tongue carries taste, ear, etc., etc. So basically what you're seeing here is everybody has their own line that they are going to go in order to ultimately find their way into the appropriate part of the central nervous system. Here's one that's a little bit more detailed. So you can actually see from the nose, the labeled line headed towards the olfactory cortex. Or from the tongue, we've got the labeled line headed towards the gustatory cortex. If it's coming from here, we need it to end up here, okay? Or let's say if it's coming from here, we want it to end up here. So where in the brain the information ends up is all incredibly important. Any of our somatic stuff, like I said earlier, the toe versus a different part of the body, it's going to go to a very specific part. It doesn't just willy-nilly it. It's not like, well, maybe I'll go here one day and here the next day. It's all very specific. So that's what I'm going to show you guys next time is how specific it is. So now, the problem is, for us, this may all work like it's supposed to. But for someone who has what's called synesthesia, this is where we have an experience that goes in through one sensory system and then out through another. So the brain labeled lines get crossed and things get confused, especially in a person with autism. So synesthesia is pretty high in people with autism. So that means that a person doesn't have the same labeled lines, and as things get interfered with one another, they might start to, as you can see here, hear a sound but experience it as a color. So in other words, they will hear the color blue. Have you guys ever watched The Good Doctor?
Yeah.
Yeah, I love The Good Doctor. Okay, so this is just a little clip right here that whenever Sean was first hired on, you guys can watch this later, but when Sean was first hired on, he talked about, he said something about the day that the rain smelled like cotton candy or something like that. I can't remember it exactly, but this is the clip. Okay, so Sean has autism, but he also has, oh gosh, what's that other thing he has where he remembers things so easily? It starts with an S as well. Savant. He has savant syndrome as well. So that's why he's so smart, because he can remember like everything. But in synesthesia, what happens is the perception of the different senses is not going to be the same for them. Because what happens is at birth, what we should undergo is neural pruning. Neural pruning means that we have different connections that help separate out these labeled lines. So by 4 months, those overlapping neural connections get removed from the brain, and then we start separating the different systems, like the vision is separated from the hearing. However, if this doesn't get pruned out appropriately, then that's whenever you can get something like synesthesia. So synesthesia, you can see on this particular graph right here that there's lots of different ways that this can be represented for different people. Obviously, you can see here letters, numbers have specific colors. Like for us, we could just say that A, B, C, D all can just be in black, right? That's the font color. But if they see colors to letters, or if they taste sounds, then things are very different in their brain. So that's synesthesia. Okay? All right, so that was our general recap, talking about our sensory information, specifically somatic senses. Next time I'm going to walk through the specific pathways for how those sensory information, how that comes from the receptors to go all the way up through to the brain. Any questions about any of that? No, you guys are good? All right. Well, I will see you guys next week.